Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Lilly.
This activity includes discussion of off-license or unapproved therapies. Please consult your local SMPC or its equivalent for further information.
Hello, my name is Barbara Eichhorst and I'm from the University Hospital in Cologne in Germany. And welcome to this program entitled Chronic Lymphocytic Leukemia Data-Driven Updates in First-Line and Relapsed Refractory Disease. So what we've got planned are several chapters that break down the treatment scene for CLL as well as for relapsed refractory mantle cell lymphoma. I will present the clinical updates for first-line treatment of CLL. Then my colleague Toby Ira from the UK will discuss advancements in relapsed refractory CLL in second line and beyond. Followed by Catherine Coombs from California, who will discuss the clinical perspective and practice implications across all different lines of treatment in CLL care. And finally, we will have as a bonus chapter Chantia from Perth in Australia, who will present recent evidence and application in relapsed refractory mantle cell lymphoma. So what do you think is the current unmet need in first-line setting in CLL? I will present you clinical updates for first-line treatment. And when we look at the landscape of frontline treatment options, we do have on the one hand side continuous treatment with the covalent BTK inhibitors, ibrutinib with or without CD20 antibody, acalabrutinib with or without obinutuzumab or zanubrutinib on the one hand side. On the other hand, we have time-limited therapy, different options here, either to combine as BCL2 inhibitor venetoclax with obinutuzumab for 12 cycles or combine venetoclax with one of the two covalent BTK inhibitors, either with ibrutinib for 15 cycles or with acalabrutinib for 14 cycles. And in addition to that, we also have the option to use a triple regimen with acalabrutinib, venetoclax plus obinutuzumab for 14 cycles. Also, just to mention that there is still the chemoimmunotherapy option, but this should only be considered in young and fit patients tolerating FCR treatment when their CLL has a mutated IDH3 status and no TP53 aberration. And also, continuous treatment with venetoclax may be used in case patients' CLL carries TP53 aberration and they do not qualify for continuous BTKI treatment. So when we consider with respect to the choice of treatment between continuous therapy and time-limited, there are certainly for both options pros and cons. Certainly the continuous BTKI treatment, in particular when it's used as monotherapy and not combined with CD20 antibody, it's very easy to start. There are no frequent visits for the patients, no IV administration. They have a low infection risk, and we also have long-form follow-up data on all covalent BTK inhibitors. The cons are that patients may have continuous side effects with the continuous administration, that we do see class effects of cardiovascular AEs. So they differ between the different covalent BTK inhibitors with respect to the incidence. But in general, all of these drugs may cause cardiovascular side effects. We also have in all these drugs bleeding risks, and we do have a financial cumulative toxicity due to the continuous treatment of these newly developed drugs. And then there's also concern on development of resistance mutations while the CLLs are permanently exposed to these drugs. With respect to the time-limited therapies based on BCL2 inhibitor, certainly the pros there are the option to stop the treatment after 12 to 15 cycles. We do see deep responses with the option of the immune system to recover. We do see so far with respect to the first data, low risk of resistance, and we also have long-term follow-up data. The cons are certainly that with BCL2 inhibitors, we have to do the ramp up in these patients, which means there are frequent visits at the beginning for the patients, associated also with a risk of tumor lysis syndrome, which is very infrequent when these ramp up is being done. However, we also see there is an effect, higher infection risk when CD20 antibodies are added either in double or triple combinations, and also due to the ramp up, inpatient treatment may be necessary in patients with increased risk for tumor lysis syndrome. And also first data, at least for the combination venetoclax plus obinutuzumab, show that there may be a higher risk for secondary neoplasia. So considering these pros and cons, the ESMO, respective shortly updated as EHA guidelines, recommend to consider for the use of these different regimen the TP53 and IDHV status, first of all, for differentiation, and for CLL carrying TP53 mutation deletion 17p, continuous treatment with BTK inhibitors is recommended in the first place. Then for less favorable CLL with unmutated IDH3 status, also time-limited therapy is recommended in the first place. You see that acalabrutinib plus venetoclax is missing. This will be mentioned in the new EHA guidelines, but independent of that, in general, also time-limited therapy comes in the first place and then followed by the continuous treatment. And this is the same case here for the CLL with mutated IDH3 status. When we look at the NCCN guidelines, they also recommend equally for patients without TP53 mutation, either BCL2 containing regimen, here only venetoclax obinutuzumab or venetoclax acalabrutinib. Venetoclax ibrutinib is only mentioned as a second less preferred option, but also equally recommended are continuous BTKa inhibitor-based treatments. And for CLL with TP53 mutation, similar treatments are recommended. Also, for example, the triple combination. Then there are data from phase 2 trials showing that the triple combination appears to be highly effective in high-risk CLL with TP53 aberration. So considering all these different treatment options, the question is certainly which of them is the best one for the patients with respect to the outcome. And this question was addressed in the CL17 trial of the German CL study group. Here we randomize patients with previously untreated CLL 1:1:1 between ibrutinib or venetoclax ibrutinib or venetoclax obinutuzumab, with the aim to show the non-inferiority of both time-limited therapies in comparison to the continuous treatment. And after 3 years in the first analysis of this trial, we do see nearly overlapping progression-free survival curves. But zooming into the subgroups in this clinical trial, when we look at patients according to the IDH3 status, again, after 3 years, we do not see major difference. The only difference we do see, which is not statistically significant, is that in particular, patients with CLL and mutated IDH3 status did extremely well with the venetoclax obinutuzumab combination. However, certainly 3 years for frontline therapy trial in CLL is still a short follow-up. I'm sure we will see more differences with longer follow-up. According to the TP53 status, we do see after 3 years that indeed patients being treated with venetoclax obinutuzumab had earlier relapses, but the difference here to those patients without this aberration was statistically not significant. At least at this time point, while there are so far no differences between the other two ibrutinib-containing treatment combinations. So trend may be here for patients with TP53 aberration, but longer follow-up is certainly needed. When we look at the side effects, we see, particular with ibrutinib, which was also in head-to-head comparisons associated with higher risk of atrial fibrillation, that this was also more frequent with the continuous treatment as well as with the combination as time-limited treatment with venetoclax ibrutinib. And on the other hand, when we looked at severe infections, we do see that the combination of venetoclax obinutuzumab in this treatment arm, while patients were recruited during the pandemic, was associated with nearly 16% severe COVID-19 infections and nearly 10% severe pneumonia, so significantly higher infection risk in comparison to the other two arms. Looking at again the development of BTK inhibitors, this very nice cartoon recently published showed that we have different ways of BTK therapies. We started with the continuous treatment with covalent BTK inhibitors, now can use either acalabrutinib or ibrutinib in combination with BCL2 inhibitors, and furthermore developed, and we have now non-covalent BTK inhibitors as pirtobrutinib, which are still active in many patients with resistance mutation to the covalent BTK inhibitors. And then even further development, but not yet approved, are BTK degraders. With respect to pirtobrutinib, there were recently 2 phase 3 trials published. One of them was the Bruin 314 trial, which is interesting because it had a head-to-head comparison of pirtobrutinib versus ibrutinib in a patient population with relapsed CLL, but also including a subpopulation of patients who were treatment naive. And the primary endpoint of this clinical trial was the non-inferiority with respect to overall response rate, which was met with 87% overall response with pirtobrutinib versus 78% with ibrutinib. And I think even more interesting is the progression-free survival. You see here splitted according to the line of treatment, that for the treatment-naive patient population consisting of 227 patients, there was at least a trend, then this is only a nominal p-value, since this was not the primary endpoint, towards a better progression-free survival with pirtobrutinib. However, in the relapsed population, the difference here, there was no clear trend so far after this relatively short observation time of 2 years. When we look at the side effect profile, we do see that cardiac toxicities as hypertension, but in particular, atrial fibrillation was less frequently observed at any grade, as well as CT3-GC or higher in the treatment arm with pirtobrutinib. And maybe all these less side effects with respect to cardiac toxicities may be cumulative other side effects occurring less frequently with pirtobrutinib showed that dose reductions were performed only in 8% of these patients in comparison to 18 receiving ibrutinib. The second phase 3 trial evaluating pirtobrutinib in frontline is the Bruin 313 trial, comparing pirtobrutinib to bendamustine rituximab. So from today's standpoint, bendamustine rituximab is not anymore a standard treatment, and therefore certainly the result is not so surprising that pirtobrutinib was shown to be superior here as primary endpoint in comparison to bendamustine rituximab. However, when we look at 24 months median PFS rate, which has not yet been reached for both of them, we do see that pirtobrutinib here has 94% of the patients still being without relapse at this time point. And certainly there are other novel venetoclax-based combinations which are evaluated in frontline as pirtobrutinib, venetoclax, obinutuzumab, the triple combination in the phase 2 trial by the MD Anderson Center. The same center is evaluating a triple combination with acalabrutinib, venetoclax, obinutuzumab versus acalabrutinib, venetoclax with a delayed obinutuzumab administration in order to evaluate if this is preventing higher risks of infections. And there are 2 phase 3 trials, both of them investigator-initiated. One of them is the CL18 trial of the German CLL study group comparing pirtobrutinib plus venetoclax either as fixed duration or MRD-driven given in comparison to venetoclax or obinutuzumab. And the MAGIC study is in comparison acalabrutinib plus venetoclax as an MRD-guided treatment to venetoclax or obinutuzumab. With that, I would like to summarize with respect to the choice between continuous versus time-limited therapies. Both strategies deliver strong outcomes, and choices are dependent on patient profiles and preferences, as, for example, genetic risk factor profile for TP53 deletion 17p, but also for IGHV status, comorbidities and cardiovascular health, risk of infections, prior history of infections, as well as patient preferences for visit frequency and treatment duration. And the non-covalent BTK inhibitor pirtobrutinib shows promise in frontline, better tolerability in comparison to ibrutinib in a head-to-head comparison, equal efficacy with respect to overall response, and a trend towards a better progression-free survival rate. However, since we use the non-covalent BTK inhibitors, so far, in particular in patients with failure after covalent BTK inhibitors and typical profile of resistance mutations, until we have more data on resistance mutations when we use the non-covalent BTK inhibitor in the front line, we should be cautious. And for the future, MID-guided and novel combinations are being further developed as novel venetoclax-based double and triple combinations or other BCL2 inhibitors, and also trials are ongoing with respect to optimal frontline strategies with respect to length of treatment, MID-driven versus not. With that, I thank you very much for watching, and please continue to the next chapter where Toby Iyer will discuss the treatment options in relapse refractory CLL and second line and beyond.
Hello everyone, my name's Toby Ayer, and today we're going to be thinking about the latest data in relapsed refractory CLL and how this latest data impacts on our treatment sequencing. So one of the key things is to define relapsed refractory disease, and this is really now based on the therapies that patients have been exposed to in the past, because patients are really moving through covalent BTK inhibitors and BCL2 inhibitors in the first line setting and in relapsed refractory disease. And of course, one needs to define whether they're exposed to these therapies or resistant to them. And there's been a number of developments in the relapsed refractory setting post covalent BTK and BCL2 inhibitors. Of course, we're increasingly understanding the mechanisms of resistance here, and that also will have some implications for future therapy. And of course, we're guided by our latest treatment guidelines, which have been published by ESMO and the NCCN. As you can see here, the ESMO guidelines are suggesting not to use immunochemotherapy, but really to be using targeted therapy throughout the relapse refractory treatment course, generally focusing on covalent BTK inhibitors and venetoclax-based therapy, although you'll note that therapies such as non-covalent BTK inhibitors are also introduced into the guideline, particularly in patients who have progressed following a prior covalent BTK inhibitors. Venetoclax-based retreatment is also considered a very reasonable option, particularly in patients that have had a longer response to venetoclax-based therapy initially. The NCCN guidelines also mirror this in very similar ways. You can see this guideline dominated by both BCL2 and BTK inhibitor therapy. But a couple of other things to note, you'll see pirtobrutinib there is considered in patients who are intolerant or resistant to a prior covalent BTK inhibitor, specifically mentioned. And also lisocabtagene maraleucel or liso-cel is also considered there in patients who have had a prior covalent BTK inhibitor and BCL2 inhibitor, and that's a CAR T-cell therapy, and I'll speak about that later. So to start with, I want to focus on the Bruin 321 study, which has led to a broad approval of pirtobrutinib post-covalent BTK, both in Europe and the US. This was a randomized phase 3 clinical trial of pirtobrutinib versus idelalisib or bendamustine rituximab. It's investigator choice in patients who had all received a prior covalent BTK inhibitor. Patients were stratified according to P53 status, and as you can see here, patients could be either naive or exposed to venetoclax therapy. Primary endpoint was progression-free survival by the independent review committee, and secondary endpoints, including, importantly, time to next therapy. Here's the baseline characteristics of the clinical trial, just to pick out a few key points here. Firstly, this was a heavily pretreated group of patients, a very high risk patient group, median of 3 prior lines. You can see up to 11 and 13 prior lines respectively, and all had received a prior covalent BTK inhibitor, and the majority had stopped that prior BTK inhibitor because of resistance. You can see over half of patients had a P53 deletion or mutation. The vast majority had IGVH unmutated disease, and a large number of patients had complex karyotype as well. And here the groups are. Here's time to next treatment or death, an important secondary endpoint of the study. And you can see here divided by whether patients were exposed to venetoclax or pre-treated. And you can see pirtobrutinib really benefits patients in both treatment groups. in those who are venetoclax naive, a time to next treatment of just under 30 months, and a median time to next treatment in venetoclax exposed patients of 20 months. Strongly statistically significant differences with hazard ratio of 0.36 and 0.37 respectively. There's been a subsequent pooled analysis of both the initial phase 1/2 study and the Bruin 3-2-1 study for patients who received pirtobrutinib second line in patients who had previously had a covalent BTK inhibitor in the first line setting. And you can see there's good efficacy in this particular setting, with a median progression-free survival of approximately 20 months in these 37 patients from a pooled analysis. Now, of course, venetoclax rituximab has been a standard of care approach in relapsed refractory disease for really quite some years now, and we've seen the maturation of the Verano trial, which is a study really historically performed in patients who'd received prior immunochemotherapy but not had any prior BTK inhibitors. And you can see that the 7-year progression-free survival and overall survival benefit remains really substantial for venetoclax rituximab. One of the really useful things about the long-term study here is we've seen the ability of patients to achieve remission following retreatment with venetoclax rituximab in this study. So 25 patients were retreated following previous venetoclax rituximab, and they actually get a good response. A response rate over 70%, median progression-free survival just under 2 years. And that really demonstrates that venetoclax retreatment is a very viable approach for a number of our patients in clinical practice. Now, the Elevate-RR study is a study on non-inferiority randomized clinical trial of acalabrutinib versus ibrutinib. This has been published a few years ago now, demonstrating non-inferiority for acalabrutinib over ibrutinib, but critically demonstrating that acalabrutinib is a safer therapy. Lower rates of cardiovascular toxicity and indeed non-cardiovascular toxicity, importantly, reduction in rates of hypertension and atrial fibrillation, key clinical toxicities relevant for our patients. And so this was one of the first studies demonstrating the second generation covalent BTK inhibitors are safer than first generation covalent BTK inhibitors. And for patients that are covalent BTK inhibitor naive, acalabrutinib remains very much a standard approach. As does zanubrutinib, based on the Alpine study. And this is a similar study in some respects, perhaps a lower risk patient group, less heavily pretreated, lower risk genomic group, but also all covalent BTK inhibitor naive. Again, the majority having had prior immunochemotherapy with a median number of lines of 1. And what you can see here is that zanubrutinib actually improves progression-free survival compared to ibrutinib in this randomized study, and also leads to lower rates of cardiovascular toxicity, less cardiac adverse events and serious adverse events, and less discontinuations due to cardiac adverse events. And then we have investigational agents of great interest. So BTK degraders that actually degrade the whole BTK protein are in active development. There are 2 of real interest. So BGB 16673 and bexabrutideg 2 that are in clinical development, both demonstrating really high levels of efficacy and good tolerability in patients who've received prior covalent BTK inhibitors, and indeed some patients that have received both a prior covalent and a non-covalent BTK inhibitor. And we await to see where these agents end up in our treatment pathways and whether they receive approvals in the future. There are other drugs in development. Just to finish on BTK inhibition, there are dual mechanism BTK inhibitors. So an example is rockbrutinib, which is both a covalent and a non-covalent BTK inhibitor. And then just to finish, there are interesting data really using both cellular therapy and bispecific antibodies in CLL. Allogeneic stem cell transplant should still be considered in young patients with high-risk disease. Timing the allo transplant is challenging given the exciting and rapid development of novel and highly effective agents in relapsed refractory disease, but certainly data suggests that it is still an active an active therapy, and although it has considerable toxicity, it should still be considered for young high-risk patients who progress through multiple lines of therapy. Now, I mentioned the NCCN guidelines have got Lysocell within their guidance, and you can see here the data from the dual exposed patient groups where the median progression free survival is just over a year, and the subgroup of patients who achieve a CR have really very durable responses, although that is the minority of patients. So, Lysocell is an option in the United States. Bispecific antibodies are also active in CLL. They have some challenges to be delivered as monotherapy because the toxicities that one see in terms of CRS, for example, are generally greater when there is a higher lymphocyte count burden in the peripheral blood. But nonetheless, here is an example of epcoritamab being an active therapy, and we certainly await with interest future developments with epcoritamab. So, in conclusion, there are highly active agents in development in relapsed refractory disease. I think second generation covalent BTK inhibitors and venetoclax rituximab are both very standard options still in the relapsed refractory setting. I think it's really important now, given that we have the potential to retreat people with the same class of drugs, to define whether patients are exposed or refractory to these dual classes of drugs. Non-covalent BTK inhibitors and BTK degraders look like oral treatment options that are well tolerated, and of course, pirtobrutinib now is approved in Europe and the US and is the most advanced in development. And then, of course, cellular therapy and T-cell engaging therapy looks highly active. And of course, optimizing both combinations of therapy and understanding their future placement in the treatment pathway, I think, is the next key step here. So thank you for watching. Please continue to the next chapter where Catherine Coombs will discuss the clinical perspectives and practice implications across lines of chronic lymphocytic leukemia care.
Hi, everyone. How do you interpret the latest clinical trial results into a clinical decision that can fit your patient's unique life? My name is Catherine Coombs. I'm an associate clinical professor within the Division of Hematology and Oncology at the University of California, Irvine. So, there's a lot of different factors that impact the choice of therapy in CLL, and treatment selection is really a shared decision making process in an ideal situation that involves not only the clinician but also the patient. And so, here are the factors that do impact the choice of CLL treatment, in my view. First is disease based features. And so, this can include IGHV mutation status, in addition to FISH karyotype and TP53 mutation status. Also, the clinical presentation of whether a patient does or doesn't have bulky lymphadenopathy, whether this is a rapid progression, etc., play into my view of what is the best therapy for this given patient. In the relapse setting, we have to think about prior treatments. And so the major considerations are: how did the patient respond to that treatment? How did they tolerate that treatment? And if it was a time limited treatment, what was the duration of the response, and time off therapy to consider whether retreatment is appropriate? Lastly, are some patient specific factors. And so, CLL, of course, is primarily a disease of the elderly. I don't think age is a number per se. I consider more biologic age, fitness, but also what are the patient's other comorbidities, concomitant medications? How fit are they? What is their access to the treatment center? And then, do they have any personal preferences? Some patients really have a bias towards not wanting to be on therapy indefinitely, in which case a time limited regimen may be more appropriate. Other patients may want something that's a bit more simple, and then a continuous BTK inhibitor is always going to be a win there. So, here are just some thoughts related to how we can sequence of our effective therapies among our patients with CLL in a relapse setting. And so, the most important question, of course, is, well, what did the patient get previously? And so, the first two bullet points relate to our most commonly utilized approach for treating CLL, which is a covalent BTK inhibitor. And so, there's two scenarios here. One is a patient who has progressed following a covalent BTK inhibitor. And so if a patient's progressed on the covalent BTK inhibitor, they can't switch to another covalent BTK inhibitor. And the reason for that is shared resistance mechanisms. And so it's just not going to be an effective strategy for the patient, for example, to switch from ibrutinib over to acalabrutinib. And so in this situation, the two best options are pretty clear based on our data and real world experience. First is to switch to a venetoclax-based regimen, and then the next option would be to switch to a non-covalent BTK inhibitor, with pirtobrutinib being the only FDA-approved option. In the setting of intolerance to a covalent BTK inhibitor, we have more options open, okay? And so if it was kind of non-severe toxicity, such as arthralgia, myalgia, headache, etc., switching to a different covalent BTK inhibitor is a great option. And so I usually go to our second gen drugs, acalabrutinib and zanubrutinib. I will say, however, there are some more like really serious side effects, such as a ventricular arrhythmia or, say, a bleeding insult that's unlikely to get better with another BTK inhibitor, because often bleeding, as one example, is somewhat similar between BTK inhibitors. That may be a situation where I actually think switching classes is better. So, again, for me, it depends on what the actual toxicity is, whether I either switch to just a different covalent BTK inhibitor or switch to a different class, whether that's venetoclax or Perto. So now another scenario is we see a lot of frontline venetoclax obinutuzumab use. This regimen's been approved since 2019, and so I haven't had a ton of patients relapse because this is an effective regimen. However, my key considerations are, is this a good person for ven retreatment? Or is this someone who I should just switch mechanisms? And there's no perfect amount of time for a patient to have had a remission following fixed duration to then say yes or no, definitely on retreatment. I would want 2 years, but ideally longer. When you think about Venoban in the front line, the median PFS is 76 months. So even 2 years is somewhat of a short response, but if they tolerated Ven really well, want to give it a try again, I do think it's reasonable, but even longer remissions, I would have increasing optimism for retreatment. The other option, especially if someone had either a poor response to Venoban or had some bad tolerability issue, perhaps they had terrible cytopenias that were refractory to growth factor support, or bad GI toxicity is another example, then I think switching to covalent BTK inhibitor would be another good option for the patient. In the third line and beyond, the options do become a bit more limited. So currently, the NCCN recommends two preferred therapies. And to be specific about third line, I'm speaking about post covalent BTKI and post VEN. And if the patient was refractory to both therapies, meaning progressed while on it or a very short duration of response to venetoclax, the two preferred approaches are pirtobrutinib or liso-cel. However, there are additional agents in clinical development, and some classes of agents that I have enthusiasm for are bispecific antibodies, but also BTK degraders, where I think will kind of increase our options for this third line and beyond space in the future. But for now, these are considered investigational. So, you've heard from Dr. Barbara Eichhorst, the clinical updates for first line CLL treatment, and Dr. Toby Ayer presented the advances in relapse refractory CLL. So, the question for me to address is what these data mean for our clinical practice. So, the CLL-17 trial, I think, was hugely important. I wouldn't call it practice changing so much as practice affirming. I think it's good to know that of those three options that were studied within this trial, there's non inferiority in that they all are going to lead to similar PFS, albeit with a short readout of 36 months. I think this one will be an interesting trial to follow over time. I wouldn't be surprised if the time limited options do drop off a little bit in the time off therapy period, but I wouldn't call that a loss for time limited regimens because, again, you have the option to retreat. Whereas if you progress on ibrutinib, you're completely done with that drug and all other covalent drugs. So the Bruin trials of the ones that examined Perto in the pre-covalent BTK inhibitor space, whether that's Perto head-to-head versus ibrutinib or Perto just as a solely frontline regimen versus BR. I think those look good in the sense that Perto is a very effective agent. The safety profile remains phenomenal. However, I do think we still have some unanswered questions, especially regarding sequencing. So we don't exactly know what's going to happen if you use Perto before a covalent BTK inhibitor. There's not really data on that. And so I think longer term follow up and sequencing information, whether it's in the context of this trial or real world studies, will be informative. But I would definitely think about using pirtobrutinib for selected patients before covalent, but they would generally have to be patients, at least in my view, that are elderly or very high comorbidity level that I don't think are going to need more than 1 or 2 lines of therapy because of this potential theoretical concern of cross resistance. CLL 18, we don't have any results on, but I love the idea of using Perto as a time limited regimen. So I'll be excited to see that trial read out once it's ready. And then Amplify, again, I think it's really great to have another time limited regimen. And so the one that got FDA approved is Acala plus Ven. This has really the beauty of simplicity. It's just an oral doublet without the complexity of the OBIT infusion. In the relapse space, of course, the 321 trial is what led to the full FDA approval of pirtobrutinib, and so now it's an option in second line. It is something I consider for patients, especially those who value simplicity and safety, ease of administration. Murano, 7-year follow-up. Obviously, Ven is a regimen in the relapse setting, in addition to what we know in the front line. And then we have the head-to-heads kind of just cementing the place of the second-gen covalent BTK inhibitors over ibrutinib. So now I'd like to walk us through 2 cases. So my first patient is a 76-year-old male who actually transferred care over to me after his prior oncologist had retired. I examined him. This is not something that he brought forth to my attention, but he actually had marked splenomegaly. It was 9 centimeters below his costal margin. He actually said that he had no symptoms from this, which was surprising to me given how large the spleen was. In reviewing prior records, it actually had been present for quite some time and only very slowly enlarging. In a further discussion with him, he just said, I am really reluctant to begin CLL treatment. The labs were a white count of 47, ALC of 42, just a mild anemia and mildly low platelets, and he has good kidney and liver function. I sent prognostic tests from his peripheral blood, and he actually did have favorable risk disease, mutated IGHV, no TP53 mutations, and then his karyotype and FISH were normal. And so I told him, you have an indication for therapy. But of course, in trying to build rapport with this patient, I didn't want to rush him into anything. So I'd actually been following him for several months and then slowly introduced the idea of potential therapeutic options. And learning about his preferences, he just doesn't like the idea of being on therapy. He also desires, if he does do therapy, he doesn't want to be on it indefinitely. And so, what are the options for this patient? Well, I think in the setting of a mutated IGHV and someone, that's always something I'm happy to hear about from a prognostic standpoint because they're going to do well with any therapy. And so, I think with him, of course, I could try to tough through Venoben, but that's a very time intensive treatment with, a high chance of infusion reactions. And in this patient who's so reluctant to get treatment, I don't want to scare him away. And so in his case, I actually thought that a Calaven would best fit his goals. It has the beauty of simplicity at the beginning, 2 cycles of acalabrutinib before adding in the venetoclax. And yes, I would still do the traditional 5-week ramp up and I would do tumor lysis monitoring, but that's something that I felt he would be on board with, knowing that this is a temporary treatment that'll be done after 14 cycles. And because of his favorable risk markers, he should be in remission for hopefully quite a while before we have to deal with this again. Continuous BTK inhibitors, of course, would work as well. But, I think this patient is someone who's not going to want to stay on the drugs. He took him a while to reestablish with me after his prior oncologist retired. And so I don't want to give him something that he just doesn't want to stay on indefinitely when that's kind of the way that we use covalent BTK inhibitors. So acalaven is ultimately what I thought was the best for him. And we're in the plans of getting it started. So my next clinical case is an 87-year-old woman with CLL, diagnosed quite some time ago in 2006. So she started on watch and wait, but then when she progressed, she received BR in 2013. She had a good response, but relapsed in 2018, and then she got ibrutinib, which she tolerated well, except for she did have worsening hypertension that was luckily able to be controlled with meds. She is now relapsing with bulky lymphadenopathy and B symptoms, and a PET was actually done because I just wanted to make sure this wasn't a Richter's transformation. However, that was reassuring. In talking to her about her preferences, she also kind of expressed a desire to just minimize the risk of side effects given her age, but also frequent visits to the clinic. The pertinent medical history in her case, she has hypothyroidism, but also osteoporosis that led to a hip fracture in 2023. And so she lives in an assisted living facility and does have limited mobility. So, medically speaking, I think she would have a good chance of response to both venetoclax-based regimen and pirtobrutinib. In her unique situation, though, I think pirtobrutinib is the best option to kind of be in line with her overall goals of therapy of wanting simplicity, low side effects, and also infrequent visits to the clinic. So, what does the future hold? We have BTK degraders, which I'm very excited about. There's one BGB 16673, but also Bexobrutideg, and these both look highly effective. It's actually maybe the efficacy looks a little bit more similar than different for these two drugs, but I'm very excited to see the ongoing development of these agents. There's also cellular and bispecific options, and so we have the FDA approval for Lysocell in the US. Epcoritamab has been studied in CLL, although technically not FDA approved in CLL, but there does appear to be efficacy in the double exposed CLL populations. Lastly, the Bruin CLL 322 trial will be one I'm looking forward to seeing the results of at an upcoming meeting. This is the comparison between standard of care VEN-R versus Perto plus VEN-R used as a fixed duration. So, as far as take home messages for our community colleagues who I know see a lot of the CLL in our country, I firmly believe again that CLL, there shouldn't be a one size fits all approach. There are choices for our patients, and I think it's our job to kind of guide our patients through what the best choice is, taking into account their unique lifestyle, in addition to the underlying CLL disease biology and these logistical concerns that come up. The next point is that there's a lot on the horizon, especially in the relapse space, and I look forward to the ongoing developments. And so, in closure, thank you so much for watching this program, and please continue to the next bonus chapter where Chan Chia will discuss the advances in relapse refractory mantle cell lymphoma.
Hello. Are you aware of current approaches to selecting and sequencing therapies for patients with relapsed and refractory mantle cell lymphoma? My name is Chan Shear. I'm a hematologist at Sir Charles Garden Hospital in Perth, Australia, and it's a pleasure to be here for this Medscape Global Oncology chapter focusing on relapsed and refractory mantle cell lymphoma, recent evidence and application. We know that patients with mantle cell lymphoma are a challenge in clinical practice, and although they typically respond to initial therapy, with successive lines of therapy, it does become harder to treat them. Following BTK inhibitors, patients do become quite challenging to manage, and in this chapter we are going to review data for recent combinations, looking at various new drugs in the post-BTK inhibitor setting. Here is an overview of some of the key novel compounds that we'll be examining, which have activity in BTK-exposed patients with mantle cell lymphoma. We'll look at glofitamab first, which is, of course, a T-cell engaging antibody which targets CD20 and CD3, pirtobrutinib, which is a non-covalent BTK inhibitor, and sonrotoclax, which is a novel BCL2 inhibitor. And their activity to date in single-arm phase 2 trials is summarized here. Glofitamab has been evaluated in patients with relapsed and refractory mantle cell lymphoma in a phase 1/2 trial exploring the agent as monotherapy. Patients with relapsed and refractory mantle cell lymphoma received obinutuzumab initially in the first 7 days, followed by glofitamab step-up dosing with a target dose of 16 or 30 milligrams given every 3 weeks from cycle 2, day 1 onwards for 12 cycles. The response rates are summarized here, and they were encouraging with an overall response rate of 85%, and a complete response rate of 78%. And this was numerically slightly higher in patients who were BTK naive compared with those who were BTK exposed in grey. But the majority of patients did achieve a CR, which is encouraging in the post-BTK inhibitor setting, with a median progression-free survival of 16.8 months after a median follow-up of 19.6 months. The median overall survival was 29.9 months after a median follow-up for overall survival of 21.8 months. As expected, cytokine release syndrome was the most common adverse event, occurring in 70% of patients, although the incidence and severity were lower in patients who received 2 doses of obinutuzumab pretreatment as opposed to 1. The adverse event profile was reasonable overall apart from cytokine release syndrome. Pirtobrutinib is a highly potent and selective non-covalent BTK inhibitor. In this phase 2 cohort of the large BRUIN study, 152 patients with BTK inhibitor-exposed mantle cell lymphoma were treated. The key characteristics of these patients are summarized here: median age 70, 21% blastoid, 28% high risk, median of 3 prior lines of therapy, a handful of patients with prior CAR-T, 20% with known TP53 mutation, and 30% with Ki67 proliferation index more than 30%. The activity of this single-agent BTK inhibitor in a BTK inhibitor-exposed population was encouraging: 49.3% overall response rate, including 15.8% complete responses, with a median time to first response 1.8 months. The forest plot here demonstrates that the efficacy was consistent across high-risk subgroups, including those with blastoid and pleomorphic histology, raised Ki67 and TP53 mutation. In terms of the duration of response, progression-free survival, and overall survival, we see encouraging activity here. The median PFS in the prior BTK inhibitor-exposed population was 5.6 months, but the median duration of response in this population was in fact 21.6 months, almost 2 years, which is quite encouraging in this setting. And the overall survival was median 23.9 months in BTK inhibitor-exposed patients. Pirtobrutinib does have a favorable safety profile in this setting, as you can see summarized here. The most frequently observed adverse events included fatigue, diarrhea, and dyspnea in the proportion of patients seen here. This was mostly grade 1 and grade 2. What's noteworthy is that grade 3 and higher adverse events are relatively infrequent, with the exception of infections, which were typically manageable, and there were low rates of discontinuation or dose reductions due to pirtobrutinib. Lastly, sonrotoclax, previously known as BGB-11417, is a selective and potent BCL2 inhibitor, and there was a phase 1-2 study for which we saw data highlighted at the recent ASH meeting, evaluating this agent in patients with relapsed and refractory mantle cell lymphoma, including a BTK inhibitor. The study design is summarized here. Patients were treated at 1 of 2 target doses with safety expansion, and there was an efficacy expansion at the recommended phase 2 dose for 103 patients overall. Primary endpoint of part 2 was the overall response rate. There was a 4-week ramping that did not require hospitalization or 12 or 24-hour post-dose laboratory monitoring. 115 patients were treated on this trial at the recommended phase 2 dose of 320 milligrams, and the baseline characteristics of these patients are summarized here. Median age of 68, mostly male. In terms of the refractory status, 87% refractory to their last line of therapy, and a number of patients with high-risk biology, including Ki67 greater than 30% at 42%, TP53 mutations in 34%, and a median of 3 prior lines of therapy, with 1/5 of patients having 2 or more prior BTK inhibitor therapy and 15% prior autologous transplant. Relatively few CAR-T exposed patients here, though. The efficacy is summarized here with a 52.4% overall response rate and a complete response rate of 15.5%, which you'll note are numerically quite similar to pirtobrutinib in the previous study. So the primary endpoint for this trial was met. The overall response rate for patients with fewer than 3 lines of therapy was 61%, after a median study follow-up of 14 months. The efficacy was promising across the study population, and at a median study follow-up of 14 months, the median duration of response was 15.8 months, the median PFS was 6 months, and the median overall survival was not reached. So similar efficacy to pirtobrutinib, at least in a non-randomized comparison between phase 2 studies. Sonrotoclax is quite a well-tolerated therapy. There was low rates of tumor lysis syndrome, and hematologic events and infections were the most common grade 3 or higher adverse events. And there is a randomized trial ongoing, and I'll show you the design in a subsequent slide. Just to highlight a phase 2 clinical trial from the Australian Leukemia and Lymphoma Group, which is ongoing. Preliminary data for this combination of glofitamab and pirtobrutinib were presented at EHA and ICML last year, with encouraging efficacy among the first 16 patients treated, with a complete response rate of 69%, and the main toxicity being cytokine release syndrome. The primary analysis for this trial, it will be forthcoming soon. So just some thoughts about how to approach patients with relapsed or refractory mantle cell lymphoma. For those who are BTK exposed and refractory, really the question is whether they're suitable for CAR T-cell therapy. And if they are, then that would be a reasonable thing to do. And for those who are not, then the next would be to really look at some of the drug classes that we've looked at today, including non-covalent BTK inhibitors, new BCL2 inhibitors, BTK protein degraders. Just to finish, a few phase 3 randomized trials in mantle cell lymphoma are of emerging interest. The Bruin 321 trial is a randomized comparison of pirtobrutinib versus investigator's choice of covalent BTK inhibitor. This is in BTK-naive mantle cell lymphoma, and a readout for this is expected in the next year or so. The GLOBRIGHT study is a randomized trial evaluating glofitamab versus investigator's choice of control arm in patients with BTK-exposed mantle cell lymphoma. Slightly less mature trial, but certainly anticipated. And then, as mentioned, the 302 study is a randomized comparison of zanubrutinib or zanubrutinib plus sonrotoclax in patients with BTK-naive mantle cell lymphoma. And enrollment of this trial continues. So we've got 3 studies there which may shape the future management of patients with relapsed or refractory mantle cell lymphoma. So I'd like to thank you for your attention and participating in this activity. Please continue on to answer the questions that follow and complete the evaluation.